Well, Kate, thank you so much for making the time today. Will start by introducing myself. I'm Nikhil Sani. I'm a partner in the McKinsey Boston office. And Kate, do you want to do a quick introduction of yourself to start?
Sure. Hi. Hello, everyone. I'm Kate Walsh. I'm the president and CEO here at Boston Medical Center, where I've served for about 10 years. Before that, I've been at a bunch of hospitals in Boston and then New York City. Been working for 40 years in healthcare. So when I say I've never seen anything like this, I really mean it.
And Kate, actually, that's where we would love to start. Boston Medical Center has been in the center and the heart of this COVID outbreak in the Boston area. Do you want to just share a little bit about how the first few weeks have been for you and the organization?
Yeah, I think it's been 45 days since we've, or a little bit longer than that, probably 50 days since we started this. And we had a couple of things that were really top of mind as this pandemic began, and it was very clear that it was going to come and affect us pretty substantially in Boston. And the first was getting our campus ready and making sure that we had what we needed to keep our staff and patients safe. And like everybody else in the country, we scrambled for PPE. And how much you need of personal protective equipment is really a function of what you think is going to happen on your campus. The first thing we did was lock down our campus and make sure that we could have only the people who absolutely needed to be here for clinical care. So a number of people work from home, and we discontinued all our elective and ambulatory activity. So for us, that meant 4,000 clinic visits that we would do a day in various buildings around our campus virtually stopped. And they've been replaced over time with telehealth visits. I can talk more about that later. But in the beginning, we were just kind of gearing up and getting ready for this.
Interesting. Kate, just to unpack one thing you shared there, I'm sure in the early days, right, the PPE was scarce. That was difficult. And to the extent you were comfortable, I'm sure you had to make some tough decisions about patients and patient care. Could you share how you did that as a leader and also how you enabled your physicians and the clinicians to do that?
Yeah, that's actually a really good question. I did not make any of these decisions unilaterally. We were guided initially by what the CDC was telling us, what we'd heard from people in other settings. But you find yourself, and I'm not necessarily proud of this, but you find yourself, in our case, we were kind of chasing what became the community standard. And so even if the CDC says it's okay for someone to take care of somebody who's COVID positive with a surgical mask and a face shield, which I think they're still saying, but the hospital down the street is using an N95 for that patient, you quickly find yourself in a position where you need to provide N95s. And then you have to go back and count, do we have enough N95s? Do we have the ones with the right size? And all of those things that that can confound your ability to respond to that in the moment. And the fact that you're kind of following the market or trying to interpret what the market's doing is really a challenging communication problem, because it has your staff kind of lose a little bit of faith in you. Like, well, if the MGH is doing this, why aren't we doing this, Kate? And it got to the point where the hospital CEOs quickly realized that we were sort of chasing each other around the supply chain in some ways, and began to coordinate how we would at least let people know we've decided that we're going to give everybody a mask when they come to work on Monday morning. And knowing that rather than chasing it made it easier, I think, for the staff to have faith in us. And then the people we relied on the most were our colleagues in infectious disease, who worked tirelessly to figure out what the CDC guidance means, what is the best practice in terms of infection control, balancing against what's actually available.
Kate, you alluded to working with the other hospital CEOs. So to the extent you can you share a little bit about how that came to fruition and what you've done jointly?
I think it started in the hunt for PPE, like, please, do you guys have any masks? And it ended up being almost a daily call at various points in time as we were trying to figure out how we could appropriately respond to the volume of cases. And as I mentioned, in Boston, our hospital surged first. So there were days when I was on the phone to people saying, I need to borrow ventilators. There were days when we would share masks or nasal swabs. I mean, swabbing people for testing. People talk about testing and platforms and all the science behind it. One of the rate limiting steps across the country are swabs. And, to actually to actually, acquire the sample, the specimen for the test. So it's, it's been a very interesting journey because the kinds of things that you talk about as a CEO are very different than the kinds of things you would typically talk about. And, you become very close to your supply chain people, and you spend a lot of time in meetings on, can we, let's model this. Can we give every person who comes into our hospital a mask? And what kind of mask? And at Boston Medical Center, the next step for us was, how do we not only protect our patients, not only protect our staff and patients, but those patients who are potentially coming to us from community health centers, and we serve a lot of homeless patients, those patients from the shelter community. So we were having, just imagine for a moment, that we were having staff in shelters without any PPE screen people for COVID-19. So, kind of almost setting up a crisis, which precipitated a significant bed challenge for us on a couple of evenings a few weeks ago.
And Kate, just continuing on that thread, Boston Medical Center is a safety net hospital in Boston. It deals with the most vulnerable populations. How have you found that you've had to change your response in light of that population, and what have you done to support them differently?
Yeah, so the first thing we did was making sure that we could get personal protective equipment to the people who needed it the most, which were those people who were caring for homeless patients. We're very fortunate in Boston to have an organization called Boston Healthcare for the Homeless, which is a federally qualified community health center that provides medical services in I'm going to make it up, at least 20 shelters around the city and around the region. So, guided by their thinking about the best way to medically care for this population, we kind of followed along with their patient cohorting. They created 4 categories of patients, suspected COVID positive without symptoms, and then need to be hospitalized. I'm short-circuiting it a little bit. And then we would work with them about the appropriate location. And we quickly realized that if we didn't have a place for people who were suspected COVID positive or COVID positive who didn't need to be in a hospital, but needed some place to recover. Remember, 80% of the people who get this don't need to come anywhere near a hospital. Most of us go home. Chris Cuomo recovered in his basement and recorded it on national television. But if you don't have a home, where do you go? And so with Boston Healthcare for the Homeless, first they started in tents. We opened up a vacant hospital building that the state owned, and we put patients in there. And now there's a convention center in Boston that also has some homeless patients in it as well. And we kind of have this like informal triage system is probably too strong a term, but idea where we know what patients will recover best in the right setting. So for example, our COVID shelter has patients who have difficulty ambulating or might need a little bit of oxygen. Whereas, because if you go to the convention center, it can be almost a half-mile walk to the bathroom, not to be graphic about it. So those are the kinds of things that we kind of developed on the fly. And they were absolutely instrumental to our ability to take care of patients. If you want to compare the experience of Boston Medical Center to some of the hospitals in New York that serve a similar patient population, I believe it was our ability to get discharges, to get patients out of our emergency room, to help our health center colleagues and our shelter colleagues care for their patients in place that really kept our system from being overwhelmed. We have had some very difficult, very trying days, and I fly a desk, so it's kind of easier for me, but and people on our campus are very, very busy, but it's never felt that kind of overwhelmed, where do we put the next patient, who gets the last ventilator kind of conversation. Fortunately, we've been able to avoid that.
Yeah. Just a few more questions, Kate. One, you alluded to with your employees, you were kind of reacting, and then you were able to get more proactive. Yeah. What have you heard from your employees, and what have you done to support them? And not just the clinicians, everyone in the hospital.
Yeah, so that is thank you for reminding me that one of the points I wanted to make is, our infection control people weren't only talking to their physician colleagues about personal protective equipment. They were talking to people who deliver trays to rooms, or environmental services people who go into clean rooms. And so the training on donning and doffing and the levels of masks that you need to wear based on the clinical presentation of the patient is far reaching and affects virtually everyone now who's still working in our hospital. One of the first video chats I did was with our in-house social worker who would go to a floor when there's been a difficult case or a staff member has passed away, and she and I talked about the need for to manage that there's trauma associated with taking care of patients like this, even if you're not directly involved in the care of that patient, and that this event is really challenging because the way you would typically recharge and rejuvenate yourself by being with family and friends or even getting a hug, those are gone. And so how do we support ourselves and take care of ourselves during this crisis? So we did a lot of work around that. We set up a 24/7 confidential, within 30 minutes, page anyone, any time of day or night, and a behavioral health specialist will be on the phone with you. We've fed a lot of people. We've had a lot of great donations. The Greater Boston community has been incredibly generous to us. We've raised, over $11 million so far for COVID-19 specific activities and employee support. We've put employees in hotels who don't want to go home and infect their families. If you are COVID positive, we put you up in a hotel and we make sure you get fed so that you don't have to put your family at any additional risk. We keep people up to date on everything that's happening, and every single day there's a COVID update for every employee. Number of patients, number of employees infected, number of discharges, deaths, number of employees who are back to work, which is a very heartening number, and that's the mechanism we've used to communicate any changes around personal protective equipment, who's providing lunch tomorrow, and everything in between.
Interesting. One final operational question for you, Kate. As you now look forward to how you might return back to normal, how have you thought about that in terms of hospital operations and what you might do differently?
Yes. So we're calling it the 4 R's. So we've talked about responding, which is what we're in the middle of doing right now, rebounding, rebuilding, and reimagining. And each R has a lot of work behind it. Responding is pretty obvious. It's what we're doing now. Rebounding is really thinking about the illness burden that's built up in the population that we serve, that we are not treating. I mean, we have usually 400 emergency room visits a day. We're under 200. Where are those patients going? Where are the heart attacks and where is the strokes? And rebuild is really thinking about how do we bring back what's important to our campus, and how do we not replicate things that we don't need to have back. Like, we shouldn't have 400 emergency room visits a day. What do we need to do in our primary care practices with our health center partners to reduce that clinical volume? I talked about 4,000 telehealth patients a day, 4,000 ambulatory visits a day. How many of those can be telehealth? If we challenge ourselves that and rebuild in such a way that it's only 2,000 a day, so our reimagining is really the last phase of this, which is, we don't quite have a whiteboard, but everybody knows our healthcare system has significant challenges. And so what could we reimagine? What's a better way to care for our patients? And the thing I'll point to is our COVID shelter. On any given day before COVID-19, there would be at least 40 homeless patients in our hospital in various degrees of kind of hanging out, waiting for someplace to go. And, they can't go to a nursing home because they don't have insurance or whatever the reason is. And how would we reimagine what this could look like? And not many hospitals would be good at running homeless shelters, but what could we do to find a better alternative to care for a vulnerable patient population that we kind of stood up in record time during this pandemic? Why can't we do that every day?
Kate, last question. What gives you hope?
Certainly the response of this team, certainly the support that the healthcare system's gotten from every quarter of this country. I mean, we're a very divided nation right now, but in most cities in this country, people clap at 7 o'clock at night, or they make homemade masks to help healthcare providers, or they're really working hard to keep their families home because they know it will save lives. And what gives me hope is that, and what I hope for our healthcare delivery system is that we can kind of repay Americans for the faith they have in us, and And we know we're going to be going into a very difficult economic time. And so what can we do as leaders of healthcare systems to help with that? And not, if we go back to business as usual and, fire up the scanners and shove people into ORs and just push volume, without sort of taking a moment to think about what we've learned and what investments our country needs to make to keep people safe, I think it's a missed opportunity. And I'm very committed and very honored to lead an organization that I think can lead the charge in changing how healthcare is delivered for the people who need it the most. So that really gives me a lot of hope and inspiration, and I'm very enthusiastic about the challenge.
Kate, thank you for everything you are doing, Boston Medical Center doing, and all the clinicians are doing. And thank you for your time today. This has been absolutely wonderful.
Thanks, guys. Bye.